Hello, welcome to this video, which is a revision video on the GCSE AQA psychology course, and we'll be looking at the psychological problems topic. So the first thing you need to know is the difference between mental health and mental health problems. So what mental health talks about is being mentally healthy, like you would be physically healthy. So those that are mentally healthy tend to have resilience. They're able to hold down relationships, friendships, romantic relationships, relationships with family. They're able to generally sleep fairly well. Obviously there's a bit of variety in there, but day to day, most of the time, sleep well, fine eating, they've got good energy levels, they can engage with the world, engage with society. If you have looked at Jehoda's list, that's another way to look at what is mentally healthy. So yeah, being resilient, being able to kind of self-actualize, set goals for the future, being able to deal with setbacks, those are other areas that you could look at. The most common mistake I see people make on this topic is when the question asks about what does mental health mean, and people then say, oh, it means people can't get out of bed, it means they're upset lots of the times, it means they've got an addiction. So just be really careful on whether the question is asking you about mental health or mental health problems and mental health issues. Of course, mental health problems and issues are something slightly different. So if you've got mental health issues, that they can be around the same things. So they could be around food and eating. So you might have an eating disorder. It could be that you've got depression, and so you've got low mood yeah, low energy, and you would then find you would struggle to maintain relationships, you'd struggle to go to work, you'd struggle to study. So just make sure you're really aware of the difference between what is mentally healthy and what are mental health issues and mental health problems. Next, you need to know about some of the facts around mental health and what's happening currently. So one thing you need to know is the incidence. So what incidence means is how often it occurs, how common it is. So it will vary depending on the research that you look at, but in general, what you find is that people are diagnosed with depression. It's about 2.6 in 100 people, anxiety 4.7 in 100, and an eating disorder 1.6. Obviously, there's lots of different mental health problems, and as I say, different research will say different things at different times. But as long as you've got some idea of some of the instance, how common mental health problems are. Other things you need to be aware of are the characteristics, as I said on the last slide. Mental health problems can affect lots of different areas, and it depends on what mental health problem you have. So schizophrenia, you might hear delusion, you might see hallucinations, hear delusions, things like that. Things like depression, it's generally sleep, eating, socializing, that there'll be impacts there. So some of the characteristics of mental health. You might also get asked about how mental health has changed and changing over time. And what we tend to see is an increase in diagnoses of mental health problems. Obviously, there are explanations for that. So something else you might be asked is why? Why does mental health problems seem to be going up? So there's a couple of reasons there. One, people are more aware, and that comes with another bit that you need to look at is the stigma. So stigma has actually gone down. People tend to talk about mental health a lot more. So is that why we're seeing an increase in incidents? Because people are more happy to talk about it. But it could be, and quite likely, that actually the world is getting tougher to live in. So you've got the cost of living crisis at the moment. You've got a loneliness epidemic where people are struggling to collect. They're doing lots of things online, like looking at videos of people talking to them. And rather than actually engaging in the real world. So that's looking at why mental health happens, and we spoke a little bit about the stigma. The last thing we might need to look at is culture, so how culture impacts mental health, and it does, depending on where you look in the world, you'll see different incidence rates. So you're then questioning, well, are these mental health problems actually problems, or are they just what's known as culturally bound? Are they something to do with the culture? An example to use is hearing voices. So in the Western world, if you hear voices in your head, you're probably going to get diagnosed with a mental health problem. Whereas in some religions, some Eastern cultures, some other cultures, actually hearing voices might be seen as a really religious experience and a really good thing. Yeah, mental health problems can be what's known as culturally bound. There's a nice overlap here between different areas in the spec. So lots of times we look at how culture affects our thinking. So you might think of the memory topic and Bartlett, and culture affected the thinking. You might look at the perception topic and where you come from changes your perception. So there's nice overlaps with other areas of the specification here. And then continuing on looking at mental health problems, there are two areas that you need to be aware of that you could get asked questions about where it impacts. So one is the individual, how does mental health affect the individual, and the other is society. So for the individual, it's probably, I've already mentioned this, it's going to have an effect on relationships, and people might not feel like going out, they might not be able to maintain those relationships, and that's going to have an impact on them. As I say, loneliness is a bit of an epidemic at the moment. There's also probably going to be an impact on coping with day-to-day life. So are people that have got severe mental health problems, are they going to be able to engage in work and education and even looking after themselves, and that leads into the next point about physical health. Lots of people with mental health problems might find it difficult to get out of their room, let alone the house, to then play in sports and look after their physical well-being. Are they going to be able to eat well, things like that? So there's a big impact on the individual. You also look at society, so the impact that mental health has on society. So we've got this instance going up. What does that mean? Well, it means that there's an increased need for social care. That's a bit of a burden on society. Society needs to provide care for those with mental health problems. You often find an increase in crime rates with those with mental health problems. Not always. There's a bit of stigma there. If you blanket say that if you've got a mental health problem, you're going to commit crime. That's not the case, but there is coincidence there. There's overlap between mental health problems and crime rates. And then there's an impact on the economy. So those that do have mental health problems, they're probably not going to be able to go out to work, so they're not then going to be paying into the tax system. As we've already said, they're going to be getting social care, so they're going to be taking money out of the system, and so there is an impact on the economy for society from mental health problems. Now we've looked at mental health problems in general, we'll then delve into two particular mental health issues. So firstly, depression, and then addiction. So looking at depression then, what is it, and how can we diagnose someone with depression? So depression in general, characterised by change in emotion. So this term low mood comes up time and time again. So if you're talking about depression in an exam question, you need to mention low mood. Behaviour, so reduced activity. Those who have depression tend to do less. And then cognition, so the thoughts, the thinking patterns tend to be more negative with those with depression. A question you could get asked is about the difference between depression and sadness, and it's a key distinction to make, an interesting discussion to have with friends or family maybe. What is the difference between being depressed and being a bit sad? Everyone's sad at sometimes. It's perfectly normal part of life. We have ups and downs, and we need to deal with that. So when we talk about depression, what we're talking about is when that's abnormal, when it's clinical. So generally we talk about the length of time that it happens for. So if it happens over a number of weeks or months, it's probably more likely to be depression than just kind of a day or two. And if it's debilitating, so if it's having a really negative effect on your life and stopping you having relationships and being able to hold down a job, things like that, then it's more likely to be depression. And we'll look at the clinical characteristics, so how a psychologist or a doctor might diagnose with depression. There are lots of different types of depression. There's seasonal affective disorder, there's many other types of depression. For the GCSE course, we just need to look into two, so that's unipolar depression and bipolar depression. Unipolar, think unicycle, one wheel, so uni one, so it's that low mood, it's the one type of depression, key low mood. If you're talking about bipolar depression, think bicycle, two wheels, so two types. So you've got this kind of mania, this manic mood, so this really happy, really high, and then you've got the low mood. So you've kind of got this up and down, really extreme. Everyone kind of goes up and down in their mood, but these are really extreme. When they're happy, they're really, really happy, they're really over the top, and when they're down, they're really down, and they've got that real low mood. So yeah, this kind of mania defined as kind of euphoria, doing lots of things that they wouldn't normally do. Okay, how would we diagnose depression then? So we have manuals. You have the Diagnostic and Statistical Manual, the DSM, which comes from the American Psychiatric Association. But we will look at the ICD, the International Classification of Diseases. And this is another manual. This comes from the World Health Organization, and they state what characteristics they feel that are necessary to diagnose someone with depression. So firstly, there's gradations, different grades of depression within there. So if you've got 2 of the key symptoms and 2 of the others, you'll have mild depression. If you've got 6 to 7 of the symptoms, you'll have moderate, and more than 7, you'll have severe. So what are the symptoms? As I said, 1, low moods. That's really key. So yeah, being down for most of the day, for most days. This generally on self-report, so they'll say that they're quite down, or there can be observations there by the clinician or friends or family. You then got loss of interest in activities and loss of pleasure. So things that people might have really been keen on before, they then lose interest in those sorts of things. And so that's a key determinant of depression as well. And finally, you've got reduced energy levels. So not being able to leave the house, not liking to leave bed. So they quite often won't do things. So those are the key symptoms. Other symptoms, you might have a change in sleep, so sleeping more or sleeping less than they used to do. You might have a change in appetite, so again, eating more, eating less than they used to do. Decrease in self-control, so lower confidence, lower self-esteem, self-loathing, not liking themselves, and lots of other areas, so concentration, attention, guilt, yeah, lots of different characteristics there. And as I say, looking at the whether it's mild, moderate or severe, or how many of those symptoms you have, determine whether it's mild, moderate or severe. Okay, so we're going to go into the different explanations for depression then. So we've got biological and psychological. So starting with the biological explanation, this suggests that people that are depressed due to nature, due to inbuilt, it's due to genetic areas, biological areas. And so you need to start looking at physiology and the makeup of the brain. So we look at neurotransmitters. So these are the chemicals that send messages within the brain, and these have been linked to depression, or a particular one. So that is serotonin. So it's thought that low levels of serotonin are linked to depression, and so this could be born. This could be there could be reasons behind this, but that's the key thing you need to be aware of, is low levels of serotonin are thought to cause some of those symptoms that we've already spoken about. So here what we have is a diagram of synaptic transmission. There's an overlap here with the brain and neuropsychology topic, also on paper 2, but linked to depression and serotonin, you need to have the awareness that this is how serotonin is transmitted via the synaptic vesicles that travel down the axon and then reach the synaptic cleft, and then the serotonin is released into the synaptic cleft, and then you have these receptors on the postsynaptic neuron, the dendrite, that then receives that information. When we come to looking at treatments, this becomes important as well, because you have a process called reuptake, but we'll talk about that in a moment. And so why serotonin is linked to depression is because the neurotransmitter is linked to lots of things that are symptoms of depression. So firstly, mood. So serotonin is linked to mood, and healthy levels of serotonin, healthy mood, low levels of serotonin, lower mood, but also things such as memory, things such as eating, appetite and sleep. And we already mentioned, didn't we, that symptoms of depression are disturbances in sleep and eating, and so it makes sense that there's a link there. It's thought that low levels of serotonin are linked to are inherited, so you often find depression runs in family, not all the time, but quite often you have depression running in families. And also excuse me, low levels of serotonin have been linked to food as well. So you've got tryptophan, which is, I've definitely pronounced that wrong, which is linked to food, to proteins that you get in kind of these high calorie foods such as cheese, carbohydrates, and so you get kind of that comfort eating. You've got low mood, low levels of serotonin, and so people kind of eat those foods to try to make themselves feel better, to elevate their levels of serotonin. So lots of links to how serotonin is linked to depression. And on my revision videos, I don't go into loads of detail about the AO3. It is really important. If you want to copy down the notes, obviously pause the video and you can get those now. But just as an overview for you, the PEC, point, explain, conclude. So there are strengths and weaknesses to this theory. Is biology one of the causes for depression? Well, there's some research support, certainly. So you look at people with depression, people without depression, and look at their levels of serotonin. And what you generally find is that those who have got depression do have lower levels of serotonin, so it is backed up by research here. However, a weakness is that that doesn't necessarily establish what we know as cause and effect. It doesn't mean that the serotonin has led to depression. Low levels of serotonin has led to depression. It could be the other way around. It could be that the depression has come about via another method. We'll look at the psychological theory later on, and that has then had an impact on the serotonin. And so we don't know which way it's going. It's kind of causal here. It's hard to know whether it's causal. It's correlational here. And so that's a weakness of this theory. Okay, and so the other theory of depression is that it's psychological. So rather than being down to your nature, it's due to your nurture. So due to your potentially upbringing, you develop depression, you develop these thinking patterns. And so that's what one of the key theories is that it is thinking patterns. So it's from the cognitive approach. It's described as being faulty thinking. So you think about the world in a way that is negative, and that kind of leads to a bit of a spiral. So depressed people tend to be pessimistic. They don't think well of themselves. They don't think things are going to get better. They think if there's something wrong with one thing, it means there's something with lots of other things. They ignore the positives. And quite often, well, yeah, predominantly this isn't based on reality. So they think things are bad when actually they're okay. It leads to this kind of hopelessness. They don't think things are going to get better. It's another area in the spec that is linked to other topics, so looking at schemas, which came up in the developmental topic, and potentially the memory topic as well. So schemas are these thinking patterns, these folders, these ideas of the world. You can get an innocent schema, which your schema of summer might be that it's sunny and you wear your sunglasses, or not if you're in the UK, it's rainy. And so your schemas are developed through your experience. And so, yeah, if you've grown up in the UK, it's probably not sun for summer. But what might happen here is with people with depression, their experiences might be negative and they might have reason to be pessimistic. And so their schema has developed to be negative. So they will see themselves as not being good enough. They will think that the future is not going to get better, and they'll think everything about themselves isn't worthy, isn't good. Continuing on with this, you've got something called attribution theory. So attribution is the cause you link to something. So, if I throw a ball and it hits you in the head, you attribute that to me. Your attribution is that I've thrown it at you. So people do this with all sorts of things. And what it's thought is that those who have got depression, their attributions are incorrect, and they attribute causes to things that don't happen, and they see the world in a different way. There's a famous psychologist called Martin Seligman, and he suggested that people have they develop what's called learned helplessness, and so they think that nothing's going to get better. They think that there's no point in trying because it's never going to get improved, and so that is their attribution style. They attribute the world to being negative. They think it's their fault, so that's known as internal attribution. They think that it is always going to be the case, so that's being stable, so it's stable over time, and they think it's global. They think if one thing is negative, everything else is going to be negative, and you can see there how that then depression is then learned. It comes from the environment, and people pick that up. Seligman did some research on dogs, not the most ethical thing, but he electrocuted the floor for dogs, and the dogs that didn't have any way of getting out, they developed this learned helplessness, and when they then did have a chance to get out, they didn't even bother. So Seligman said that this could be a same kind of thinking pattern in humans. Okay, so that's our first evaluation. There is research support here for this idea of thinking patterns, this learned helplessness, specifically in Seligman, and these dogs learn not to try after. So it shows that depression and this faulty thinking pattern can be learned, can develop over time, can come from nurture rather than being nature. Another strength is that the psychological theory has been applied into the real world. So one of the most common treatments for depression is CBT, cognitive behavioral therapy, cognitive thinking, behavior acting, and therapy. So cognitive behavioral therapy aims to change people's thinking patterns and their behavior. And it's fairly successful. So people going through CBT, generally their symptoms reduce and their depressive thinking improves. It doesn't get worse, and they can change their thinking pattern. The fact that it works in the real world, the fact that we can change people's thinking, suggests that the theory itself is sound and built on strong foundations. The weakness here is that you're saying that having a negative attribution and being pessimistic all the time is a bad thing. Well, not always. And actually what they found is when they tested depressed people's view of chances of things going well and the future, they were actually more realistic than people that didn't have depression. So actually, are depressed people seeing the world in a better way in some way? It's still seen as a disorder because it's stopping them taking part in the world, but actually maybe the thinking pattern itself is actually maybe fairly accurate. So having looked at the explanations, psychological, biological, we're now going to look at therapies and treatments for depression. So we're going to start with biological. So if you think that depression is caused by low levels of serotonin, the most likely treatment is you think, okay, we'll give them some drugs to increase their levels of serotonin, and that's what the main biological therapy is. So it's known as an SSRI, selective serotonin reuptake inhibitor. Goes back to that theory. I showed you the synaptic transmission. And what happens is an SSRI prevents reuptake of serotonin in the synaptic cleft to the presynaptic neuron. So let's have a look at the diagram. And basically what's happening with synaptic transmission is that the neurotransmitter is released into the synaptic cleft, and then the postsynaptic neuron, the dendrite, then takes that neurochemical and sends the message on. Another process is also happening, and that is known as reuptake. So the presynaptic neuron also takes some of the neurochemical back. It stores it for next time. It improves the speed of transmission and means that the neuron knows what to send next time. So an SSRI, selective serotonin reuptake inhibitor, so if you inhibit something, you're stopping it. So what an SSRI does is it stops the reuptake. So it doesn't necessarily increase the overall amount of serotonin, but what it means is there's more in the synaptic cleft to be able to send as a message because it's not being taken up for the other one. So in general, there's more serotonin to be able to send the message. So, low levels of serotonin, if the theory is that causes depression, if you can increase the amount of serotonin that's able to be sent, then you should see a reduction in symptoms. So let's see what happens. So SSRIs have been found to work. They do reduce the symptoms of depression. However, the evaluations we're going to look at here, there are 3 weaknesses because there are drawbacks to this. So serotonin SSRIs are still popular treatments. They are still given to people with depression, and they do tend to reduce the symptoms. However, there are problems here, and that's where we're going to look at for our evaluation. So the first problem is that there are side effects. So it's not just a free hit. You can't just take the drugs. Smarties, happy Smarties, we're all fine. Actually, they are powerful drugs, and they can have other impacts such as nausea, sickness, insomnia. We've already said people with depression, their sleep might be affected. Weight change, we've already said people with depression, their appetite might be affected. Anxiety, increased suicidal thoughts, and you don't want that in people with depression. So you have to be really careful about recommending drugs for people with depression. And while there has been lots of research that has found benefits, it's not consistent, and actually the reasons why are unknown. So it can sometimes work for, they do work for lots of people, but they can sometimes not work for some people. And also the effectiveness has been questioned. So we don't necessarily know why why the drugs work. So as soon as you take an SSRI, it's blocking the reuptake, so they should happen straight away. However, you often find that the depression still lingers and the symptoms don't reduce for 3 or 4 months, and no one really knows why. So that's a bit of a problem with the drug. You're diagnosing something and you're recommending something and prescribing something, and you don't actually know how it works. Could just be a placebo, although SSRIs have been tested against placebos and found to be more effective. But yeah, certainly question marks over the efficacy, effectiveness of the drugs. And probably the biggest problem is that the drugs are seen as reductionists. So what this means is you're taking a very, very complex condition. Depression really affects people. It impacts their lives massively. And if you speak to a depressed person, it's all consuming, whereas you're saying, okay, just take this drug, it will lower your it will increase your serotonin that's available, and it will reduce your symptoms. So it's quite what's known as reductionist. So what reductionist means is that it takes a very, very complex idea and explains it in very simplistic forms, which is essentially what the drug treatment does. And it's much better to take a more holistic approach where you account for the individual, their needs, and everything around it. So that's one of the big problems of the biological therapy for depression. Next, then, we look at the psychological therapy for depression, and as I've already mentioned, that is CBT, cognitive behavioural therapy, or cognitive behaviour therapy. So what is cognitive behaviour therapy? Well, cognitive is thinking, and so therapy, we're trying to change those irrational thoughts. So if we think that depression is caused by negative schemas and faulty attribution and faulty thinking about that's internal, stable and global, then we need to try to change that. Trying to stop the depressive person catastrophizing, thinking about the worst possible outcome in all areas. Behavior, we want to try to change the way they act. So this is, a process called behavior activation, where they look at how they're acting in their day. They try to, they'll focus maybe on one positive a day and see how that might change their emotions, might elevate their mood. And then the therapy part. So it's quite important that this is guided. So you'll often have a therapist. The therapist will often dispute. So the depressed person might say, oh, I'm rubbish at everything, it's never going to get better. So the therapist might challenge that and say, well, actually no, you might think you're not very good at that thing, but actually look, there's lots of things going forward, there's good things, there are things to be positive about. So they're challenging these irrational thoughts and trying to get the person to do that themselves. And one of the key bits of that is the individual needs to do that themselves in their own life. So they're given what's known as homework. You get a thought diary, and it might document the negative thoughts, and then they're trained to challenge them themselves, to try and help themselves. And you can see here how actually changing the thinking pattern might not just work while they're taking the drugs like SSRIs, but actually can help them for that particular area and for later in their life. So where SSRIs can be seen as reductionist and taking a complex thing and making it too simple, the CBT is more holistic. So it's looking at the individual, it's looking at their lives, it's trying to apply it to the whole person, and accounts for not just how they're feeling now, but potentially how they're feeling in the future as well, and trying to kind of get to the underlying cause of the thinking and of the problem, rather than just treating the symptoms, which is what happens with drug treatment. I've already mentioned this point, that drug treatments also deal with the underlying causes and issues potentially in the future, not just what's happening now. So it's a long-term treatment that sustains and really kind of backs up that theory that the faulty thinking patterns have a role to play here. So CBT sounds brilliant, but actually, if you think about it, someone who's depressed, you're getting them, they're going to have to get out the house to begin with, which is not always going to be easy for someone who's got depression. They're then going to have to willingly engage in treatment, and again, not always going to be easy. They're going to have to put time, effort, thought into the CBT, and that's quite difficult for someone who's got depression. It can take weeks, can take months, lots of homework, and so this kind of quicker fix is what lots of people with depression kind of need, and so what you find is high dropout rates. So lots of people that enter CBT don't finish it and go back to their ways, and so that's a problem there. And how do we get them to really buy in. What generally happens actually in real life is that you get a combination. That's where the key study comes in that we'll look at in a moment. Okay, so the first key study in the psychological problems topic is Wiley study. And this was to test, that combination between CBT and SSRIs and look at what impact that takes. So they were looking at this holistic treatment for depression. They used people that were known as treatment resistant. So people that maybe hadn't responded to antidepressants, didn't really work with them. And so looking at, can we combine these things? So they basically offered people CBT with drug treatment. So the drug treatment maybe reduced their symptoms to allow them to get into CBT, and then the CBT dealt with kind of the long-term aspects. So the aim of the study to see whether combining CBT, cognitive behavioural therapy, with antidepressants was better than just giving them antidepressants alone. So what they did, they recruited participants from places in the UK, Bristol, Exeter, Glasgow. GPs recommended participants, patients, and these patients were all treatment resistant, which meant that they had tried drugs alone and they hadn't worked. And it had been for a decent amount of time, so over 6 weeks, and their BDI, which is the Beck Depression Inventory, so it's a questionnaire that assesses levels of depression, were over 14, so they had high symptoms of depression, essentially. These participants were then randomly allocated to either just antidepressants or antidepressants and CBT, and they looked to see then what the outcomes were. What they found was after 6 months, 90% of the participants were still in the study. Of those in group 1, 21.6%, let's call it 22%, had 50% fewer depressive symptoms. So even the ones that were just taking the antidepressants, it did seem to work. However, the big finding here was that those that were doing CBT and the drug treatment, 46.1, call it 46%, had 50% fewer symptoms. So the CBT and the antidepressants worked really well together. And after 12 months, 84% remained, and group 2 had better recovery and improved remission. So symptoms really reduce. What does that tell us? CBT works really well, especially if participants were previously resistant, and CBT and antidepressants together are more effective than just drugs alone. So the benefits can be maintained over a decent amount of time, and it really backs up both of those bits of research that we're looking at in terms of the therapies, both biological and psychological, for depression. Okay, so this was a randomized controlled trial, so it was a really well conducted study. We could call it a lab experiment. It was very controlled. Confounding variables were thought about, control was put in to begin with, and then the outcomes we can really measure against. So we can really trust the research here. The validity of the study is really good. But no study is perfect, of course, and there were some issues here around the methodology. So one of the problems here was that it was self-report. So participants giving their depression score, they were giving that themselves. And so there could be bias there. Participants might not know how they're feeling themselves. And so that could have a potential impact on the validity of the study. And finally, this treatment was found to be holistic and have real world application, and actually really cost effective. So when we look at putting this into real world practice, it can be taken up, which is great. And we obviously started this topic looking at the cost of care, the cost of society, cost of the economy. Well, this is a really cost effective method of treatment, and it's been found to work from a research methods point of view. So lots of strengths here. And now we'll look at the second of the two mental health problems, and that is addiction. So firstly, we need to define what we mean by addiction. And so there's been a couple of definitions. Griffiths firstly started looking at the difference between a like and an addiction. And he said that this was salience. So what does salience mean? Salience means that something becomes the most important thing for someone. People do this thing over and above all other activities. So they'll drop work, they'll drop family or friendships for doing the addictive behavior. There's also definitions to be made around dependence and substance abuse. So these are two defining characteristics of an addiction. By dependence, what we mean is that this is needed for addiction, so there is a need to have this thing. So that could be a pain medication, abusing a pain medication, or misuse of a pain medication. There's withdrawal symptoms. So if you're dependent on something, you have withdrawal symptoms. So these are generally physical, so you get headaches, sleep problems, and they could also be psychological if you're dependent on something. I think I might be dependent on coffee. I definitely get withdrawal symptoms if I haven't had enough. And then finally, there needs to be substance abuse rather than misuse. So what do we mean by abuse and misuse? So misuse, not following the rules, having too much, having too little, taking something for its wrong purpose, gas canisters are used for whipped cream and not for inhaling by a balloon, for example, or abuse. So abuse is needed for an addiction. So this is used to get high, used to escape, used to numb, used to change one's mood, used to medicate oneself that a medical professional hasn't diagnosed. And much like in depression, there are clinical characteristics, and you could be diagnosed by a GP or a psychologist. So again, I've mentioned previously the ICD, the International Classification of Diseases from the World Health Organization. So they have definitions of what an addiction is. So what they say it's a mental and behavioral disorder due to psychoactive substance abuse disorders. So that's what it's categorized under. What are the symptoms? What does this look like? So 6 key symptoms here, and you'd need 3 or more of these symptoms over a year to be diagnosed with an addiction. So first, a strong desire to use the substance. So compulsion, you feel like you're maybe not in control of it. Persisting despite harm, so you know that whatever you're doing is causing you harm, but you're still doing it. So you know that there's evidence that if you carry on drinking, it's going to hurt your liver, but you do it anyway. Difficulty in controlling use, so if you're told to cut down or limit it, you can't do that. And a higher priority given to the substance over the other things, so you might give up other pleasurable activities, you might have had hobbies that you don't do anymore, you might not be going to work or school because the substance is meaning that you're more interested in that. And a withdrawal state, so this means that if you don't have the substance, then you feel worse, you get the shakes, you might get vomiting, lots of bad negative impacts happening there with withdrawal. And there's also tolerance, so what that means is that more of the drug is needed to get the same buzz, or more of the substance is needed to get the same buzz that a lower level used to be able to get, so you get tolerant of it, you need more and more to maintain that buzz. So 3 of those things over the past year, and you're likely to be diagnosed with being addicted to that substance. Much like in looking at depression, when looking at addiction, you'll look at theories and therapies. So the first theory of addiction, again, much like the depression, is the biological theory. So this suggests that if you're addicted, this comes from your biology in some way. So there's thought to be hereditary factors. So again, it is thought to run in families. Addictions are thought to be highly inherited. So if there's history of addiction in a family, that does tend to run through. And we have this term called genetic vulnerability. So it's not this kind of self-fulfilling prophecy where if you've got someone in your family who does have an addiction, you're definitely going to get one. No, but it might make you more susceptible, and given a particular environmental stressor, if you have that stressor and you have the predisposition, the biology that will then trigger that, then it may make you more vulnerable and more likely to get an addiction later on. And you have this diathesis stress model, which is just that. So it says that there's an interaction between your biology, what you're born with, your genes, what you've inherited, and the environment. So someone could be born with the predisposition to get an addiction, but actually the environment they live in doesn't dispose itself, so they haven't got access to drugs or alcohol or whatever it may be, whereas another person may not have the biological underpinnings and be in an environment that lead to it, and they might not get an addiction either. So it would require the genetic predisposition as well as the environmental stressors or an environment conducive to addiction. Next, we come to the second named study, which is Cage's twin study, and this is looking at that biological theory of addiction. So what happened here, the aim was to see if alcohol use did run in families, it was inherited, there was heritability there. This was conducted in Sweden, and they used what was known as temperance board registration. So this is where people have got in trouble with the law, with the authorities regarding alcohol. And so they were looking at twins, male twins, somewhat identical and somewhat non-identical. So identical twins monozygotic and non-identical dizygotic. And so what the study was looking at was the difference between temperance board registrations with identical twins compared to non-identical twins. And what was found was there was 61% of the identical twins. If one twin had issues with alcoholism, the other one did as well, whereas the non-identical, it was 39%. So the fact that those that had a higher genetic similarity, identical twins, had more in common when it came to alcohol problems suggests that there is some sort of biological inherited predisposition to alcohol problems. It wasn't 100%, so identical twins share 100% of their genes, so if it was just the genetic underpinning, you'd expect to find exactly the same. So there wasn't. So it's this kind of diathesis stress model where it does seem to be an increased chance, likelihood, but it's not direct. And so environmental factors do play a role as well. So in evaluating the study, there are obviously weaknesses. One of them is that the research methods was an issue. As I say, we're talking about addiction here, we're talking about alcoholism, but the way that was defined in the study was these temperance board classifications. And so is that actually alcoholism? It's more arrest for drunken disorderly behaviour. And some of this data was self-report data as well, so think of your research methods evaluations there. Can we actually trust the validity of the definition, the operationalization of alcoholism? The next evaluation is down to looking at whether the biological explanation actually is helpful or not when it comes to addiction and alcoholism in particular. So if you think it's genetically inherited, then, and there's just genetic vulnerability, those that have maybe got addiction in their family might think it's inevitable when it's not. There's just an increased risk there. And what this might mean is that the role of genetics might be overplayed and overrepresented when actually there's multifaceted implications and reasons for addiction. But the strength of the study is that it's been supported by other research. So other research, well-controlled research, has also found that there's a link between alcoholism and genetics and twins as well. Different rates, but still in the same direction, that the identical twins, the monozygotic twins, tend to have a higher rate of alcoholism when one of the twins does as well. So there's research support for this study and the biological theory of addiction. Next, then, we look at the psychological theories of addiction. So it could be down to the biological, which suggests it's nature. Psychological is due to nurture. So it's saying your environment has a role to play in addictive behavior. So a couple of theories here. One of the key ones, social learning theory. This comes up quite heavily on A-level or degree. But what social learning theory says is that we follow the actions of others. If we see other people behaving in a certain way, and especially if they're like us, if they're similar age, similar sex, similar cultural background to ourselves, we're likely to imitate their behavior. This is a famous study from Albert Bandura, presented to children with a bobo doll, a fake doll. They showed adults hitting the doll and then presented the doll to children, and we looked at what they did, and what they found was if they're the same sex model, the children were likely to copy that. So apply that to addiction, and we could say that the environment and the friends and the peers, the people that we're around, if they're displaying addictive behaviors, then there's a potential there that we can pick up those behaviors from from others. Leaning on kind of looking at social norms, so looking at the social topic, we see that that has a role to play. So there are these rules about social behaviour. Think of the conformity topic. There's implications there. So if you're in an environment where others are displaying these addictive behaviours, then you may well likely be likely to do that as well. And then you've got this social identity theory. So if we want to be accepted by the group, we would likely do it as well. And if you're in an environment where your peers are engaging in addictive behaviour, whether that's drugs or smoking or drink or whatever it may be, you've then got more opportunities, you've got more access to those things. There's an environment there, it becomes more socially acceptable, and you might behave as others do to be accepted. Okay, and a strength of this theory is that it's backed up by research support. So the study mentioned here was a meta-analysis, looked at lots of other studies, and they found the vast majority showed a strong relationship between peer behaviour and smoking behaviour. So if you're in a group that smokes, you're more likely to smoke because you're in that social environment, the social norms are there. The weakness would be that this isn't a causal relationship, so it could be the other way around. It could be actually you want to smoke, you want to drink, so you surround yourself by other people that are doing those things. So it's not the social group that are causing you to do the behaviour, you're doing the behaviour and you're finding other social groups that reinforce that. And so can we say that a social group is the cause of the behaviour? Well, probably not. It's more correlational. And the other strength of this theory is if this is the case, then we can use that information to try to help people. So we can get people to see that the vast majority of people aren't addicts, aren't engaging in this destructive behaviour. This is used quite often with marketers. So if you want people to switch energy tariffs or buy a certain phone, actually saying please buy our phone, please use this tariff doesn't work as well as saying 80% of people in your age group are using an iPhone, for example. You are more likely to conform to that behaviour. So people designing treatments for addictive behaviours or issues with substance use can use that information and can try to help people in those social groups. Okay, and so we've already looked at the theories, psychological, biological, and now we're going to look at the therapies, the treatments. So one of the treatments coming from the psychological explanation is aversion therapy. So psychological theory saying it's nurture, it's your environment, you kind of learn to have these addictive behaviours. So if you want to treat that, what you can say is, well, if you can learn to have these addictive behaviours, maybe you can unlearn it or learn not to have it. And that's what's been used. So we use something called classical conditioning, again, not really mentioned that much on the GCSE specification, which is quite surprising because it's a really key theory in psychology and behaviour. So you've got Skinner and Pavlov, who looked at learning theory, and Ivan Pavlov did a famous experiment called Pavlov's dogs, where he looked at stimulus response. So you think of a puppy is born, and the puppy would salivate if it was given food. So the food would be an unconditioned stimulus and salivation would be the unconditioned response. What Pavlov found is that when he was going into his lab and a bell was rung, the dog would associate the sound of the bell with getting food, until eventually they would just need to ring the bell and it would salivate. The bell to begin with would be a neutral stimulus. It wouldn't mean anything to a newborn puppy, but through learning, through association, the dog has learned that when they hear the bell, they're then going to get some food. And so the bell becomes a conditioned stimulus to the conditioned response of salivation. So we can use that and that theory in treatments, and it's called aversion therapy. So that Pavlovian response and that aversion therapy has been used in lots of different areas in terms of addiction. So you've got maybe alcohol, gambling, smoking. So alcohol, for example, they have paired drinking alcohol with taking a drug called antabuse. Antabuse causes vomiting. So what they were hoping to do is make people that were addicted or had problems with drinking associate that feeling, those thoughts and drinking with vomiting, until eventually they should start thinking, oh, I want to drink, actually I'm not going to because I'm going to throw up. So you've got that stimulus response, that's aversion therapy. They're learning that a negative outcome is going to happen straight away from the drink. In gambling, they got heavy gamblers to think of their gambling behavior, think of words they associate with gambling, and then just gave them, casually, give them an electric shock, give them some give them something negative, and again they should start associating the thoughts of gambling with negative outcomes, so they hopefully unlearn that gambling behavior. And then smoking, again, similar idea. They got smokers, heavy smokers, people who want to stop smoking, to smoke loads and loads and loads and loads until it made them feel really, really sick. And again, it should associate that thought, that behavior, that the smell of smoking with a negative outcome. And so this is what aversion therapy is, trying to learn a negative outcome will happen. And so it's an application of the psychological theory. And so here I've linked those things to unconditioned stimulus, USC, and unconditioned response, neutral stimulus, what the behavior is to begin with, the learning phase, and then the conditioned stimulus, so the outcome, and that's linked there. So again, I'm not going to dwell on this too much. If you want to copy this down, pause the video and go for it. So does aversion therapy work? Yeah, it has been found to be really successful. So it can limit the behaviours and reduce those addictive behaviours of drinkers and gamblers and smokers. It's seen as quite a holistic approach because you're tackling the underlying cause as well. So if you can, especially if you combine it with CBT, so stopping people having those thoughts about that behaviour, having those actions about that behaviour, and so the outcomes can be really successful. So that's a strength of aversion therapy. The weakness, however, is that it's really hard to get those people to go follow through with the treatments, because obviously you're getting them to take drugs when they're take drugs that are going to make them vomit when they're drinking. You're giving them electric shocks. You're getting them to smoke until they're feeling sick. So it's not a nice experience. It's not a pleasant thing to do. And so the people have to be really determined and really on board with wanting to get better, because there's high dropout rates, and so that makes it difficult to know how effective it actually is. Because obviously there's kind of this confirmation bias. Those that go through it, we say, oh great, it's worked for them. Well, actually they're at a level where it's acceptable. Maybe if your addiction is so bad or you need those substances so much, you're just not going to go through the treatment in the first place. So that's a negative of aversion therapy. It's very difficult to stay in. And the other weakness is that the long-term benefits have been questioned. So it tends to work in the short term, but the effects have been reduced certainly after a year, and after 9 years it's kind of no better than a placebo. So again, you'd question the effectiveness. Maybe it's a nice short-term treatment, but probably something else would have to be happening to really kind of help someone through that addictive behavior. And then we're going to look at the second therapy for addictive behavior, and that is self-management. It's linked again to the psychological treatment, and self-management or self-help groups. There's lots of different ways this can be done. The most famous are what's known as 12-step programs. You might have heard of Alcoholics Anonymous. You've also got Narcotics Anonymous, and this is a program that people go through to try to help to break the thinking pattern and the behavioral patterns that are associated with those addictive behaviors. And so 12-step programs, as they suggest, you have to go through 12 stages. In general, what they do is they make someone believe in a higher power than themselves. It started out as a Christian therapy, but actually it's bigger than that now, and those of other beliefs or no belief can still go through it as long as they believe that there's something bigger than themselves. That's one of the key parts of getting through the 12-step program. You have to let go of your own will, your own self. You also have to admit to the guilt and shame. You have to know what you're doing was negative to yourself and maybe others around you. You have to confess. You have to accept what you've done in the past was poor. You also need to look at this kind of lifelong process. You need to know that you're probably going to be going through this process for the rest of your life. You need to help others that are in the group. You need to log it in a book, and then you can join groups and go to those regularly. There are other self-help programs and self-management programs, but the 12-step program is probably the most famous and well known. So one of the big benefits of the self-help 12-step program is that they are holistic. They look at the whole person. They look at the thoughts, the behaviors, the emotions, the feelings that go along with the addictive behavior. So it's starting from the bottom up, and they're committing to themselves to get better, they're committing to their own future, but there's also that social support, there's groups to help people as well. So yeah, a really good psychological treatment here, whereas something like aversion therapy might be reductionist because you're just looking at the behavior itself. In terms of research support, it's a bit of a mixed bag when it comes to the 12-step program. There was a big review, the Cochrane review, and actually it found no statistically significant difference between Alcoholics Anonymous and other treatment types. It's also hard to track those that drop out because they might not want to take part in the research. So it's claimed that there's a very high dropout rate, kind of 81%. So yeah, it's very hard to truly know the effectiveness of 12-step programs, and so that's obviously a weakness of the therapy, of the treatment. And finally, it might only be those that are already really motivated, that were kind of going to get better anyway, that benefit from it, because you have to get to that stage. You have to get to a stage of admitting that it's bad, of looking to the future, to really be able to see this through. So were they kind of in there anyway, and the 12-step program was just kind of the icing on the cake? Really difficult to know. Hope that was helpful. Bit of a whistle-stop tour of the psychological problems topic. Best of luck in any of your upcoming assessments.